welcome to Focus on Health, a show on all matters health, wellness, and lifestyle. I am your host, Joy Fender, and on this episode, we discuss diabetes alongside Dr. Rilwan Aden of the Lions Diabetes Care Center. But before then, take a look at the health updates. Very informative health updates right there. And like we said, we have Dr. Rilwan Aden from the Lions Diabetes Care Center who's taking us through diabetes. Dr. kindly introduce yourself to our audience.
Thank you very much, Joy. My name is Dr. Rilwan Aden. I'm the head of the Lions Diabetes Care Center here in Loresho.
Okay, let's just start with the basics. What is diabetes?
So diabetes is a broad term, just talking about a metabolic condition where you have basically high sugars in your blood. And these high sugars come as a result of defects in what we call your hormone insulin. So insulin is a protein which is usually produced by the pancreas. So when there is a defect in production of this hormone insulin, your sugars tend to rise. Or sometimes your pancreas can produce this hormone, but your body resists, your cells resist the action of this hormone, which is actually to take sugar from your blood into your body cells. So it's basically the defect in the production and resistance of this hormone to your body that leads to a high blood sugar state, and that is what we actually call diabetes.
And other types of diabetes, one which especially affects kids, one which affects elderly people.
Okay. Yeah, there are types of diabetes. There is type 1 diabetes, there is type 2 diabetes. So when you try to categorize it in children and adults, this was sort of the traditional classification that we had, where it was actually thought that type 1 diabetes exclusively occurs in children and type 2 diabetes exclusively occur in adults. So it used to be adult onset the type 2 and the childhood diabetes type 1. But this has been research has actually led to us now knowing that type 1 diabetes can also occur in adults, and so the classification of adult onset and childhood diabetes is now sort of abandoned, and we now have what we call the type 1 diabetes and the type 2 diabetes. So type 1 diabetes essentially is where you have what we call it's an autoimmune condition, in the sense that your body's own immune cells attack the pancreas where the insulin is produced. And so you have a deficiency in insulin because these cells that produce this insulin, remember insulin is that protein that makes sugar leave the blood and go into the cells. So when you don't have this protein, you actually have high blood sugar because its function is to remove blood from the cells. Its function is to remove sugar from the cells. So now when you have your own immune cells now attacking the cells that produce this insulin, you tend not to have the insulin. So this is type 1. It occurs in children, but like I said, we now have adult onset type 1 as well. So it can also occur in adults. Type 2 initially starts as what we call insulin resistance, where your body is producing the insulin, but your cells are resisting the uptake, the function of this insulin to occur as it should, and this can occur especially in the people who have obesity. Fat cells can prevent the action of this insulin. So type 2 diabetes eventually, if not controlled well, can also lead to your insulin being deficient. And that's why you see some of the people with type 2 diabetes initially starting taking oral medication, and then they end up injecting insulin thereafter because of the depletion of the insulin that sets in later on. So broadly classified is the type 1 diabetes, type 2 diabetes. There is the gestational diabetes, which tends to occur in pregnancy. And so you tend to notice that these patients during pregnancy, they have diabetes, it's being managed, and 6 weeks postpartum, the diabetes is no longer there. But these patients are highly likely to develop type 2 diabetes. So these are the patients who should keep screening themselves when they, every year at least, to see that they are getting diabetes or not getting diabetes. A lot of times in our setup, we don't pick out the gestational diabetes, but we tell mothers, if you've had a big baby meaning any child with a birth weight above 3.9 kilograms, that's a likely patient who actually had a gestational diabetes or pre-diabetes and should actually be screened for diabetes. And that child also eventually has to screen for diabetes because they have a likelihood of diabetes. We have other forms of diabetes which come what we call secondary diabetes. So there's some hormonal conditions like when you have increased hormone called cortisol, increased hormone called growth hormone. So when you have this increase in these hormones, you tend to get diabetes as well. So these are secondary, and also some medications that we give for certain conditions like the steroids. Actually steroids tend to increase your sugar, so you can have steroid induced diabetes as well. So these are the secondary forms of diabetes, the classification, the broad classification. Scientifically, there is a lot going on in the world of classifying diabetes. We have more and more coming up in the sense that we have a lot of patients who are not obese, but they're having type 2 diabetes. Previously, people used to think if you're big is when you have type 2 diabetes, but now it has been noted that in sub-Saharan Africa and the black population, there's a lot of what we call the lean type 2 diabetes, and so the classification is still ongoing as research keeps on going and bringing in new stuff. Yeah.
You've mentioned obesity and the fact that maybe a mother would have had a big baby. I'm considering these are risk factors also.
Yes.
So what are some of the other risk factors for getting diabetes?
So for risk factors, we have what we call non-modifiable risk factors, in the sense that your age, above 45 years of age, you're highly likely to get diabetes, and so you should screen for your diabetes. You have males are usually middle-aged men more predisposed compared to women to have diabetes, so your gender can predispose you to diabetes. And then we have our African setting as well, in terms of our race can predispose us to diabetes. And then you have those which you can modify in terms of the obesity, which you talked about, because weight loss tends to prevent diabetes if you're obese. And you have smoking, you have alcohol use, you have high blood pressure, you have high cholesterol levels, and so these are things that you can actually work around. Your sedentary lifestyle, your diet, your exercise, all these are things, risk factors that can predispose you to developing diabetes.
And I'm pretty sure a lot of women are concerned. Does oral contraceptives also lead to getting diabetes in some way?
Well, oral contraceptives not directly linked. Oral contraceptives directly linked to what we call thrombotic state, where you can have blood clots, probably highly predisposed to that, but not directly, but indirectly in some sort. You have some patients who come in and they say they tend to gain weight when they use the OCP, the different types of OCP. Some don't gain weight, so probably indirectly through the weight gain, but not direct effect of the oral contraceptive. Yeah.
Let's just go to the signs and symptoms of a person who has diabetes, especially children, because not many people actually do know that children can get diabetes, so they may say, it's probably not diabetes.
Yeah. So children, depending on the age group, I'm not a pediatrician, but definitely in terms of the age group, you can tend to know easily if, for example, type 1 diabetes develops quite fast because of the destruction of the immune cells, although now science is finding that there are stages in the type 1 diabetes as well, which we didn't know before. But the common symptoms, I think, of that you can notice is actually frequency in passing urine, and these children tend to feel thirsty more than usual, and sometimes you can say it's hot and they're drinking a lot and they're passing a lot because they're drinking a lot, but it's good to note the amount as well that they're drinking. And then in some aspect there is what we call polyphagia, that they tend to eat a bit more than usual, because again, remember, the sugar is just in the blood. It's not getting, the body is not sensing that there's food coming in, so they tend to eat a lot. And then there's weight loss, because again, your body is not being built, sugar is just remaining in the blood, so weight loss is another big factor that happens. But generally, even in the adults, type 2 diabetes can be quite silent. You can have type 2 diabetes for some time and you don't notice. Even before talking about type 2 diabetes, it's important for me to talk about pre-diabetes, because you can know that you're going into diabetes before you actually get the diabetes, by actually doing your routine checks in terms of your fasting blood sugars, early morning sugars before eating, and you get to know the range. But it can entirely be silent. You wouldn't know. So some people can still be having the same symptoms in terms of the weight loss, in terms of the frequency in passing urine, frequency in wanting to drink water, and blurry vision. Some people can get dry skin. Some people can get some urogenital infections frequently. Some people can get skin infections in terms of getting frequent boils here and there. So they should actually watch out, especially if you have a strong family history of diabetes. I think it's important to mention family history is another strong risk factor for diabetes.
This diabetes is so bad. What are the main symptoms? So, for example, diabetes ketoacidosis.
So diabetes ketoacidosis happens in patients who are not producing insulin. So it can happen commonly in type 1 diabetes, because like I explained to you, type 1 diabetes is the destruction of the beta cells that produce the insulin. So they don't have insulin at all, or rather they're deficient of insulin. And remember, I mentioned to you, type 2 diabetes patients can also get deficient of insulin, so they can develop diabetes ketoacidosis. So diabetes ketoacidosis is where now you have the deficiency in insulin, so you're not getting insulin in your system and you're not injecting the insulin. So in type 1 patients who are on treatment, if they skip their insulin and their sugar goes high, this is a state where now the body converts its metabolism from the normal, what we call glycolytic pathway, using glucose as a substrate for metabolism, and now your body starts producing more acids than usual. So DKA severely can produce in symptoms like they can have abdominal pains, they can have it starts off with fatigue and not being able to, weakness and all this, and then you have abdominal pains, you have vomiting, intractable vomiting that happens. And when you see a diabetes patients having vomiting like that, you should check their sugars and you should check what is called ketones. So I know routinely we don't have ketone meters at home for people to check their ketones, but ideally that's what should happen, especially for the type 1 patients. So those are the common symptoms that come along, and if not taken care of, the DKA can actually lead a patient into a coma. Yeah, it is a diabetes.
Most of the people who are actually using the insulin also tend to go to lower levels of blood glucose. Is also that also
Yes. So we call it hypoglycemia. So hypoglycemia is an emergency as well. So hypoglycemia is the level of sugar where you start getting 3.9. That's your alert to know that your sugar is going low. So now less than 3.5, you definitely know you're in hypoglycemia, and so you should be able to correct this hypoglycemia with 15 grams of glucose. So I know sometimes patients get really scared and they overdo it. So you check with 15 grams of glucose and then you recheck your blood sugar after 15 minutes. So 3 times correct it with the 15 grams. So 15 grams can be about probably the soda, probably about half, or rather juice, that you can have half of it. So you correct with that, check every 15 minutes. If it doesn't come up, you should be on your way to the hospital, at least the first time, because now the correction will have to be through injectable. Yeah, so it could also lead to a coma. So sometimes you can find a patient with diabetes who's out completely, and that could, first thing we do is check their sugars to confirm there is no hypoglycemia.
We're taking a short commercial break. Do not touch that dial. But before then, take a look at the Did You Know segment. Welcome back to Focus on Health, and we are continuing the conversation on diabetes alongside Dr. Rilwan Aden. Take a look.
So we've talked about the signs and symptoms and all. How do we manage diabetes?
I think sort of I've mentioned a few pointers on that. For the type 1 diabetes is only insulin, and the treatment remains insulin until now, and insulin is an injectable. So type 1 ideal management is to try and mimic the normal body physiology, like how a person who doesn't have diabetes should insulin behaves, and so we tend to call it a basal bolus regimen. So we give one basal, which is a sort of a long-acting insulin, and then before every meal they're supposed to inject themselves to be able to take care of the sugar that comes in with that meal. So ideally it's one three bolus, which is before breakfast, before lunch, before dinner, and then the once a day, which most people take at night, and some people take in the morning, the long acting one. So that's the type 1. So for the type 2, it can be both insulin and oral. So I think I should have started by saying type 2 diabetes management is highly individualized. Every patient is different, every patient's condition is different. So when we meet our patients, we do a thorough medical history and medical examination, and followed by investigations, because type 2 diabetes especially has complications that come in very fast, and sometimes we diagnose these complications at the initial diagnosis. So you can find a patient who comes in and you diagnose type 2 diabetes today, and they're already having chronic kidney disease. The kidney is already damaged, or the eye is already damaged at first diagnosis. And some patients, they come in as emergency, they're having a heart attack, and that's when you diagnose the diabetes. So these patients who have what we call multimorbid, that is complications associated with the diabetes, and this is usually the driver of what we call mortality. The deaths in diabetes is the complications. And so we have medications, different medications, some targeted towards these complications, and some targeted towards prevention of these complications. So previously, traditionally, we used to focus on managing diabetes as just the sugar. So this diabetes is not just the sugar, but it's also the complications that it brings about. And so from the outset, we have to work with the prevention of these complications, and we have newer drugs which have come in to try and prevent these complications, which we actually, depending on the patient, so we risk stratify them. Are they at high risk of developing these complications? Are they at low risk? And so management is tailored towards different patients depending on how they present. So a key factor is also, in terms of preventing complications with type 2 diabetes, is hypertension, high blood pressure. A lot of times patients with diabetes have high blood pressure because these are all lifestyle diseases. They sort of follow each other. And so blood pressure has to be managed adequately. High cholesterols, because again, a lot of times this high sugar, when it's in your blood, it gets converted to fat, and you get what we call high triglycerides and cholesterols. So you need to manage these patients' cholesterols, because again, cholesterols is the drivers of some of these complications, including heart attacks and strokes. So these are the things that you have to manage together and watch out for. And so as we are managing the patient, it's a long-term management, it's a chronic disease, it's a chronic management, and the management is not only dishing out medications. Foundation or initial management is essentially lifestyle, including the diet. And so diet is now a big part of therapy, in the sense that we individualize patient meal plans. We make them the meal plans through our nutritionists, and we individualize these meal plans based on what's available for the patients and the calorie intake of the patient, and so that we can, as much as possible, reduce the sugar level in the body. Because if you look at our local diet, it's highly carb-based, carbohydrate-based, and this drives sugars high. And so depending on the patient activity, that's why I'm saying it's highly individualized. So a high carb diet, if you're highly active and you're really burning the calories, is okay for you. But if you're taking a high carb diet and you're not highly active, so we try and balance that for the patient. And so that's why we say it's individualized, and each patient has their own one-to-one consultation with the nutritionist, and we start from there. And then again, complication based. If a patient has chronic kidney disease, there is a special diet that they should have. So these are all part of management, and it's broad management, not just looking at controlling that sugar and bringing that sugar level down. Yeah.
You've mentioned some complications, including problems with your kidneys, but I would want you to expound further on the connection between diabetes and your eyesight. What is the relativity between the two?
So diabetes, eyesight complication. When you come to diabetes and the eye, the common complication is actually what we call retinopathy. And retinopathy, allow me to just use a bit of jargon: retinopathy, neuropathy, and nephropathy. So this is eye damage, kidney damage, and nerve damage actually have a common it's grouped as what is called microvascular complications of diabetes. This means the small vessels in your body, when they actually start getting what we call atherosclerosis, rather damage, they lead to these complications. So when you see a patient has eye damage, always also check their kidney, always check their foot, because again, neuropathy leads to foot complications, which we'll discuss. But what retinopathy is the commonest eye complication, but there are other eye complications, including patients living with diabetes are highly predisposed to having cataracts. They're highly predisposed to getting glaucoma. So how it affects the eye is actually quite complex. And so it's once a year. Even if a patient living with diabetes does not have any eye symptom, the eye has to be checked. So every once a year, if you're a patient living with diabetes, please have your eye checked. Despite the fact that you do not have any symptoms in your eye, it has to be checked once a year. Yeah.
What are these eye symptoms?
So a lot of times you have blurry vision. Some people tend to lose the eyesight just suddenly because, again, diabetes is sort of affects your vessels, and so you can get the vessels in the eye getting affected, and they can get thrombosis, and you just have sudden vision loss. But diabetes eye complications is actually gradual vision loss. Slowly the patient keeps losing eyesight kidogo, sight kidogo kidogo. Yeah.
So can diabetes be cured?
Diabetes does not have a cure, at least as of today. Science research comes up, we don't know what the future holds, but diabetes does not have a cure. However, diabetes can be managed adequately to prevent complications, and patients have a comfortable life. We have had terminology diabetes remission, where patients actually, through their lifestyle modification, attain good control of their blood sugar levels, and we stop medications in some patients. But these patients are not cured, so we follow them up still. They've gone into what we call remission, and so they need continuous follow-up, because we have had a lot of patients who have gone into remission and have gone back to medication again. But I repeat, diabetes does not have a cure.
So how many times should an individual who doesn't have diabetes check their sugars, especially after the age of 45?
So is this a patient living with diabetes or no diabetes? Normal diabetes. So we actually advise annual check, and then when you have pre-diabetes, now you should actually have follow-up, because now pre-diabetes we get into aggressive prevention of developing diabetes. So you're a patient not having diabetes, have your annual checks done to at least check that you don't have diabetes. Yeah.
Can an individual with diabetes live a normal life just like any other person?
They all are living a normal life. So yes, they can, absolutely. Diabetes, if managed well and without the complications, like some of the complications we mentioned can cause a bit of disability, because diabetes is amongst the commonest cause of blindness, is amongst the commonest cause of non-traumatic limb amputation. So if not properly managed, it could lead to complications that can lead to disabilities. But other than that, even with the disabilities, patients live quite comfortably if managed well. So I think it's a condition which individuals can live quite comfortably with. But I emphasize on, and all my patients know this, and we discuss, and I always tell them to ask questions. Diabetes management is 90% on the patient. And so self-management of diabetes is actually very important. And we have support groups at the hospital, and we encourage people to learn more about their own self-management and share, because they learn a lot from each other on how to cope with some of the situations they're in together. And so I would encourage the self-management aspect in terms of patients learning about the condition, and use the healthcare providers to get more information about what they're experiencing outside their sugars. When it comes to diabetes, not only probably us, it's probably from us, the healthcare providers, but patients are so glucose centric, basically sugar centric, focusing on those numbers. But I think ultimately quality of life is very important as well. And so that is the kind of conversations we should be having with our patients, so that they're comfortable and they live life comfortably.
Yeah, that was
Yeah.
such an interesting conversation, and give us your parting shots in relation to diabetes.
I have a lot of parting shots, but I think for today we could probably talk about diabetes is a condition, like we've said, that patients can easily and comfortably live with. But I like talking about prevention. Diabetes can be prevented, especially in our youth right now. We're getting more younger population being diagnosed with diabetes, and that's mostly around the lifestyle. So I would like us to focus on our lifestyle, healthy lifestyle, eating right, moving more, and I think quality of life is actually a focus when we talk about diabetes management. And so enjoy life.
Very informative conversation we've just had, and just as Dr. Rilwan has emphasized, other than taking your medicine, lifestyle modification is key in managing diabetes. I have been your host, Joy Bofenda, and until next time, stay safe, stay healthy, and live with the Healthy You segment.